Hello, this is Michael Altos, and we are starting a section on uptake and delivery of inhalational anesthetics. This is recording part 1. Inhalational anesthetics are different from most of the other drugs that we think about in pharmacology. Giving a drug through the lungs allows extremely rapid action, fast changes in level of anesthesia, both increasing and decreasing, faster turnover, quick recovery times, with a tremendous margin of safety. The lungs are a unique system of delivery because if you think about it, they are the only organ that gets 100% of cardiac output. Before we get into the physics and the chemistry of uptake and delivery, let's just talk about general anesthesia for a moment. General anesthesia is sort of a spectrum of effects. There's amnesia, which occurs in the hippocampus, the amygdala, the temporal lobe. There's sedation or hypnosis or being asleep, unconsciousness. That occurs in the cerebral cortex, the thalamus, the reticular formation. There's also muscle relaxation or immobility, which probably occurs more in the spinal cord, and there are also some supraspinal effects. And there's an analgesia component, which involves peripheral and central receptors. This graph shows that as we give more anesthesia, we see an increased number of patients becoming amnestic, and then at higher concentrations becoming unconscious, and then at much higher concentrations, everyone eventually becomes immobile as well. What's interesting is that these effects can be achieved with a vast array of different compounds. Things as simple as an inert element like xenon, or an inorganic compound like nitrous oxide, hydrocarbons like halothane, or even complex organic structures like barbiturates can all achieve what we call general anesthesia. There are a lot of different theories about the mechanism of general anesthesia. It seems like each agent has its own mechanism. And furthermore, each aspect of general anesthesia may also have its own mechanism, as we just described. The unitary hypothesis states that all the inhaled agents probably have some common mechanism of action. There is an idea called the Meyer-Overton rule, which says that potency correlates with lipid solubility. And so that makes it seem like being lipid soluble has something to do with being a good general anesthetic. Some think that the agents bind to the lipid bilayer of cells in the CNS and make it expand, or maybe it disturbs the form of the membrane or decreases conductance of the membrane. But the main theory that is accepted currently is that anesthetic agents bind to ion channel proteins, whether it's GABA receptors, glycine channels, nicotinic acetylcholine channels, or NMDA receptors. And that's the mechanism for general anesthesia. Now, before we get into the details of inhalational anesthetics, we have to do a little bit of a physics review. The first concept that's very important to understand is partial pressure. Partial pressure is the pressure that a gas exerts on something, and it's proportional to its fractional mass. And partial pressures are additive, so let's look at an example. Atmospheric pressure at sea level is 760 millimeters of mercury. We know that air is basically just oxygen and nitrogen. It's 21% oxygen, so 21% of 760 is 160. And it's 79% nitrogen, which is 600. And 600 plus 160 adds up to 760. So the partial pressure of oxygen in air is 160 millimeters of mercury. If you took all the oxygen out of the atmosphere and all you had left was nitrogen, you would have a pressure, an atmospheric pressure of 600 millimeters of mercury. The partial pressure is the pressure each gas would have if it alone occupied the same volume. So imagine a container. And we're going to think about this container because the problem that I had when I started learning this is that we're dealing with gases dissolved in solution. And we all know about pressure. Pressure is when you have a gas packed into a container, and that's pressure, and that's easy to understand. And we know about concentration. That's when you dissolve something in a solution. And solubility is just how much something can you dissolve in a certain volume of liquid at a standard temperature. These are all pretty intuitive concepts. But what does it mean when we talk about partial pressure of a gas in a solution? And this is where I started to get a little bit of confusion. So I thought about a container like, imagine a bottle of soda, where you have gas, like carbon dioxide, dissolved in the water. And it's filled right up to the very top. So it's just filled only with water, and there's gas dissolved in it. So when we talk about the partial pressure of the carbon dioxide in that water, we're thinking about how hard is that gas trying to escape from solution? Or to think of it a different way, imagine that there was a little bit of air in the top of that bottle. And so some of the carbon dioxide does come out of solution, and it occupies this air, and it creates a certain pressure. The pressure of the gas in this part, in the air part of the container, is in equilibrium with the gas that's dissolved. And so we can say that the partial pressure here is equal to the partial pressure in the liquid. Let's expand this idea a little bit more. The idea that gases equilibrate based on partial pressures and not concentrations. So let's imagine two containers connected by a tube. One container has, let's say, water. The other container has, let's say, oil. We pressurize this container with a gas, like a volatile anesthetic, and we let it equilibrate. So the anesthetic can dissolve in the water a little bit. It can dissolve in the oil quite a bit more. And so the concentration of anesthetic in the oil is much higher than the concentration in the water. But this whole system is in equilibrium. What is in equilibrium is the partial pressure. We know that the pressure in both of these containers is the same because there's an opening between them. And so therefore the partial pressure throughout the entire system is the same. So if that's the case, we can create the same system, but without the air. Just two containers separated by a membrane. And this might be comparing two different body fluids. Now we have, once again, a gas, like a volatile anesthetic, equilibrating between the two compartments. And equilibration means it has the same partial pressure. Even though the concentration is different in these two compartments, the partial pressure is the same. This is a really important idea that you need to have clear in order to understand the rest of this discussion here. Now, one thing that may confuse you a little bit is that we don't always use the word partial pressure. Sometimes we talk about fractional concentration. So, for example, we don't say the partial pressure of oxygen is 160 millimeters of mercury in the air. We say it's 21%. When we say 21%, it means 21% of atmospheric pressure, which is 21% of 760, which is 160. So F, the fractional concentration, is proportional to P, the partial pressure. So when we talk about things equilibrate based on partial pressure, we could also say they equilibrate based on fractional concentration. The thing you need to know is that physiologically, your body needs the partial pressure to get the physiologic effect, not the fractional concentration. So, for example, if you go up to a really high altitude, say on Mount Everest, the FiO2 on Mount Everest is still 21%, but it's 21% of a very low atmospheric pressure, less than half of the 760 that we breathe at sea level. And so patients will be hypoxic. They will feel short of breath because, and you might say, well, why? They're getting 21% oxygen. The 21% oxygen is true, but it's 21% of a very thin air. And so they're not getting the 160 millimeters of mercury oxygen that they need in order to get adequate tissue oxygenation. We're going to see the same is true with anesthetics. Let's stop here. Please take some time to review these very basic concepts because understanding them well is going to help you in the upcoming recordings. Let me know if you have any questions.